Local programming on KRWG made possible in part by viewers like you. Thank you.
Welcome to Especial Fronteras, A Changing America. I'm Edmundo Resendez. Today, in our monthly series dealing with Latinos and mental health, from stigma to treatment, we take a look at how New Mexico State University is tackling the issue on mental health care. Welcome to Especial Fronteras. And our guest today is Esther Duvall, PhD, from the department, she's department head at NMSU Family and Consumer Sciences. Welcome.
Thank you.
And John Schwartz, a PhD, Associate Dean of Research at the NMSU College of Education. Again, a special thank you for being here today to discuss an important subject to our community. Let's start the conversation by discussing how these two programs came together to bring mental health coverage to the Southern New Mexico community. And maybe we could start out with you, Professor Schwartz.
Well, I came here about 5 years ago and came here as department head for the Counseling and Educational Psychology Department. And one of the things that I felt like was a real opportunity is there was a need in the community, and we had a counseling clinic that was really seeing people mostly in a training capacity and was not serving the community. And so when I got here, I really thought we need to figure out a way to meet the mental health needs in the community and give our students real world training. And so kind of on that idea, I ended up connecting with Esther. Maybe she can take it from there.
Esther, and how did you come about in working on this project?
Well, again, we had a facility also that we used to see students and their families in our Marriage and Family Therapy Master's Program. We have a facility at the Family Resource Center where we would see students and their families, but sometimes we would have people who weren't students who wanted to come see our therapists in training, and we weren't able to see them. And so I was also very interested in the idea of having a facility on campus that we could see community members, again, to give our students more experiences and then to meet the need in the community for more mental health providers, especially for those who don't have insurance.
So let me understand this correctly. There is a community center that brings in or allows for people, members of the community that may or may not be, students at NMSU, that can come in to the center to seek mental health coverage.
Correct.
And our mission really was that Esther and I really wanted to serve people without resources in our community. So we have, so far, we serve an average of 100 to 120 clients, and those are people without resources. So everyone we've served up to this point has been pro bono. And that was really our mission, was to serve people who have trouble getting services in the community because of lack of resources.
And what was the immediate reaction when you started doing this project? Did you start seeing some patients right away, or did it take time to grow and develop?
We did start seeing patients very quickly. We had a lot of support from our administrators who helped us initially pay for someone and then eventually a full-time person. At first it was half-time. There was some concern, for example, by campus police and housing and some of the programs that are for children on campus about having people with mental illness come on campus. And so we did have to talk to them and assure them that there would be some screening processes in place to ensure everyone's safety, but also to remind them that people with mental illness are just like everybody else, and the people who have mental illness are already here on campus. There's already plenty of us on campus who have mental illness issues, so it's not like it's going to be something so different.
And we're going to talk about the role that stigma plays in mental illness in just a bit, because that's very, very important. Seeking help, mental health help, it can be very intimidating. There's an intake process that people have to go through, in particular for people that are seeking mental health coverage for the first time. How does your organization work to educate the community about overcoming the intimidation process so that they can truly seek the help that they need?
One of the things I think is really important in every community is to be part of your community. So we really work with our faculty and students to be an active part of our communities. People will know them and know what they do. One of the projects that I was really proud of that our students did was work at the Anthony's Women's Intercultural Center, and they actually ended up having a fair where they just educated the community about mental health issues and where they could seek help, and made it in a fun way where they had games for kids and they had food, but really going out to the community and educating them about there is help available and try and destigmatize some mental health issues. I think that's really important.
We also worked with different providers in the community to let them know that we were going to be having this service. Many of them were frustrated because they did have long waiting lists, so that a person might call wanting help, a person particularly who didn't have insurance, and it might be 6 months before they could get in to be seen. And that was frustrating for the providers in town, so they were happy to know that we might be able to see these people, more quickly. So we reached out to the providers and let them know about what we were doing and got their support. So that, in addition to sort of reaching out to the community, reaching out to the providers, the other mental health providers.
What challenges existed out there with people that could not afford to go to a mental health provider, with them lacking health insurance or even lacking just enough money to, pay to go see a doctor, even though they needed somebody to talk to, and they might have put it off. And as you mentioned, you really wanted this to be pro bono. Mm-hmm. What kind of challenges existed before, and may still exist, out there as far as people that need mental health coverage but can't afford it?
Well, there's also the barrier of transportation. So there's the barrier of not having money. There's the barrier of maybe of not having transportation. So we tried to make sure, for example, that our facility was located near to a bus stop, city bus stop. There's, of course, lack of knowledge. And then there's just the fear and the stigma. So again, trying to do things to reduce that stigma and to let people know who we are, and to make sure that when they did reach out, whoever answered the phone or the first contact was very warm and able to establish rapport, and very importantly, be able to speak their language. If it was somebody who is monolingual Spanish or just felt more comfortable talking in Spanish, we wanted to be able to make sure that they felt like they would be able to be served.
And one of the issues I think that we talk about a lot is issues of mental health disparities. And to me, that's a kind of a systemic issue. So it's the idea that people who have low resources, often racial ethnic minorities, fall into this mental health disparity area where often there's less access to quality mental health services and less culturally competent services for those individuals. So, and a lot of that is a resource issue, that when people don't have insurance and can't pay fees, it costs a lot of resources to serve them. And so often there's long waits for them to be served, difficulty getting the right services. So, and this is not to criticize any entity, but to say that this is a need everywhere. And so, and I think some of this is going to change. I mean, I don't want to go off on politics for a long time, but I think some of this is going to change with the Affordable Care Act, which I know has positives and negatives, but having access to mental health services and thinking about kind of ideas like patient-centered medical homes that includes behavioral health services, I think is really important.
Throughout this entire series, we keep coming back to one word, and it's already come up a couple of times today, and that's the word stigma. And there seems to be a lot of stigma on multiple fronts. You look at, anybody that has a mental disorder, there's a stigma, whether they're Hispanic, they're African American, they're Anglo. But as we look at the role of stigma, that how difficult is it as you seek these patients that might have never considered going to a mental health provider? What role does stigma play in you with these patients as they come in for the first time?
It plays a great role. There was a national survey done that said that only 25% of people felt like the way that other people looked at a person with mental illness was caring, supportive, and sympathetic. In other words, 75% thought that people had a lot of judgment and looked down upon or were afraid of people with mental illness. And when we look at what is stigma, there are a lot of components to stigma. There's fear, there's pity, there's blame, like blaming the person, it's your fault, you should just be able to stop this, pull yourself out of it. There's a sense of avoidance, like I might catch this from you, so that sense. And there's even a part of stigma is thinking of like we just want to like lock them away, keep them away from the rest of us. So all kinds of elements to stigma, that it's really a complex issue.
In the role of patients for Latinos, that again, and I'm thinking of first generation Latinos that might be here, that might be, as you mentioned, monolingual, and might have not considered mental health coverage, in their native country, and they're coming here. feeling as though they need the help, but what role does stigma play with some of these patients?
I think it's a huge role. There's all these statistics on the percentage of people who have mental illness who actually seek help, and it's really low. So, and then can they get the help they really need, the quality of help they need? So I think it's really both sides of that. And so I think there's a lot of work to be done in educating people about mental illness, what causes it, how you treat it, how treatable a lot of common mental illnesses are. I think people really are unaware that a lot of mental illness people suffer with their whole lives and have had generations who've suffered with that are really treatable now. So I think getting that word out is really important.
You know, you just mentioned something very important, you know, family history. You know, the role of family history for a lot of these, you know, first-time patients that might be coming in, the realization that they might start, when they start thinking about, you know, my uncle, my father might have suffered from mental illness. Is this something that's very common that you may see in your clinic?
Absolutely. If you do a family history and you can see it over generations, again, that there's oftentimes a genetic component. We don't understand all the causes of mental illness, but many times there is a genetic component, and you see that it's does tend to occur in clusters and families, and so yeah, you can very much tell that. And then just again helping people realize that, you know, other kind of medical diseases run in families: heart disease, cancer, arthritis, and there doesn't seem to be the same stigma for that. People don't blame them. You know, it's not your fault you got arthritis. And you also don't think you're supposed to just snap out of arthritis or cancer or heart disease. You realize it's a chronic long-term condition. The same thing can be true with mental illness. It's a long-term situation that might need some treatment. But it's not like something you're going to snap out of, and your mother didn't cause it by the way she parented you.
Oh, I was just going to say, often when you hear someone who comes in for the first time, they're the first person in their family to actually come to counseling, they often talk about a history of people who had behaviors like they're struggling with who never sought treatment. So you see that history, you can figure it out even though those people were never officially diagnosed or received appropriate treatment. They just struggled with it their whole life, which is really sad when you think about it.
Well, let's talk about, continue with the conversation on stigma. You know, what needs to be done to do outreach on the stigma from the community, from people that may not be aware of what mental illness truly means? As you mentioned, you know, if you mention to somebody the word cancer or diabetes, and then you mention the word mental illness, bipolar disorder or schizophrenia, there's totally different reactions. What kind of outreach are you working with or should be worked on to educate the community about overcoming the stigma?
Part of it is just education, understanding, you know, how common these things are, that it can be treated, that we shouldn't use words like, you know, crazy, and we shouldn't look at people with fear or pity or, again, blame them.
I'd also really want to say, I'm a big believer in prevention. And so now you see in the schools, there's a lot of information that kids have about eating healthy and exercising and taking care of their bodies, but really not much about taking care of their mind and about mental illness. And early on learning, for example, like you were saying, what depression is. If you learn that, what are the signs when you're 11 years old? You learn to recognize those signs and recognize it in your friends and have it normalized for you. That a large percentage of people will suffer. You know, you have a class of 30, you could have 10 to 15 stand up and say, in your lifetime, probably more, you're going to suffer from some type of mental illness. And if you normalize it at a young age, when people face it in themselves and their friends and their family, when they're older, there'll be a different response to it.
And I think that plays an important role in how, you know, you might have a friend that might be suffering from depression, and being able to identify that they're suffering from some form of depression, and being able to work with them and, you know, offer a support role, a support role with that. But as we look at Latinos becoming the largest minority group in the United States, and they're spreading beyond the traditional Southwest and, you know, California, what are schools like NMSU doing to train students to prepare to deal with this community for the future?
One of the things, there's a lot going on related to that, and I really feel like we can be at the forefront, or are at the forefront of that kind of training. And one component is training people to counsel bilingually. And that really means more than just being bilingual. It means thinking about being able to do mental health counseling and use that terminology and do therapy bilingually. And so we have one of the few in the country bilingual minors and specializations in our department, where we train counselors, school psychologists, psychologists to be bilingually competent counselors. The other part is doing culturally relevant treatment. And there's lots of components to that, but one is thinking about a collectivistic culture and how a collectivistic culture may deal with mental illness versus an individualistic culture. It would be just one component of that.
So both of our programs make a lot of effort to try to make sure that we recruit a diverse group of therapists and counselors in training. So for example, in our program, in the Marriage and Family Therapy program, about 75% of our students are Hispanic. And if you look sort of nationally, only about 3% of marriage and family therapists are Hispanic. So we're trying to train, a large number of Hispanics or Latinos to become family therapists, so that, again, when people come in, they see someone who's like them and maybe who's familiar with their culture. And then again, both of our curriculums put a lot of emphasis on cultural competence, understanding the characteristics, and so that you understand, for example, that the whole family might be coming to see you, that it might be grandma and Aunt Susie and the children. You're not just thinking that one person's going to walk in your door for help.
And again, it's my understanding that from different people I've talked to, in particular psychiatrists, who say, what's important to them is not just the person that comes in seeking the mental health help, but the people that come with them, their support system. And I think that again, overcoming stigma is involving family and letting them be aware of what they're going through.
Because we as therapists or counselors are not going to be with people for their lifetime, but their family and friends will. So you really want to build up that support network.
What about language barriers? Is this something you have seen play a role in seeking or in talking to patients?
If you don't have bilingual therapists, sometimes people have had to resort to having children translate, and that's a really hard position to put a child in a family, especially when you're talking about something as sensitive as counseling and mental health issues. So, either you have people not coming for services because no one can speak their language, or you have someone trying to accommodate them and speak their language who's not skilled at it, or you put a family member in the position of translating. None of those are ideal.
And research shows that even if someone is fully bilingual, they're more comfortable talking about emotional issues in their first
Native.
language. So it's important to have bilingual counselors.
Let's talk about self-medication in drugs and alcohol abuse. What role does that play in the Latino community as people that might be suffering from a mental disorder, that might not be aware that they're suffering from a mental disorder, and it's not a good combination?
I mean, I think you said it perfectly, that that people who don't seek treatment often tend to self-medicate. And sometimes the way we find out there's a mental health issue, like if you think about primary care psychology, where maybe they have a behavioral health expert, is they'll see certain patterns of abusing substances that are treating some underlying disorder. So you may see someone who may have ADHD and they've never been diagnosed using a lot of stimulants because they're trying to control that without really understanding it. So I think it can be an important diagnostic criteria, but also it can be a way someone deals with it without seeking help.
Right.
that can mask it.
Men in particular are less likely to seek mental health, and they're more likely perhaps to turn to alcohol and drugs to self-medicate, because in most every culture it's sort of a macho expectation that you're not supposed to show signs of weakness, and so lots of times men have a difficulty asking for help and might turn to alcohol or drugs instead.
Let's talk about acculturation, assimilation. As you look at second and third generation Latinos, Hispanics, that might be a little bit more familiar with through friends in mental health help. Do you see that as being the case, that they're more open to seeking mental help?
I would say, there's such individual differences in that. Like Esther was saying before, in general, men don't seek help as much as women. And in general,
Latinos maybe less so
than
Anglos.
Yeah, and some of the research I've done has looked at those issues and how to help men seek help, and how to help racially ethnic minority men seek help. And often some of those programs have aimed at people who are married, aimed at their partners, to bring them in to counseling. So I think there may be some acculturative aspects to seeking mental health and being more comfortable with mental health issues, but I think there's so many individual factors that play into that too. We have men, Latino men, who don't seek health care.
Right.
You know, who because of gender roles and because of kind of their role as the protector and caretaker for their family, and they don't want to be seen as weak. So I think, yeah, all those play into it.
Are there any areas in particular in southern New Mexico where you're seeing more patients coming from, or you know that have surprised you?
Yeah, not really. There wouldn't be a place in southern New Mexico. One of the things that we're really involved in our department is working with primary care physicians, doing behavioral health, which is part of what I mentioned before, the Affordable Care Plan. And we see a lot of people who go through that route to now seek mental health services. So they wouldn't ever go to a counselor, but they would go to their primary care physician. And now that we're thinking more holistic, more integrated about mental health and health issues, then you may see them go there and then be led to the right mental health. So maybe they come in for a medical issue that's really a mental health issue, or they come in for a co-occurring mental and medical health. So if you're in pain all the time, that's going to lead to depression, but people often don't treat then the depression that leads from that.
What kind of outreach currently exists to reach out to the Hispanic community to educate them about mental health and the resources that might be available to them?
Well, this show obviously is a great resource. I'm really pleased that you're doing this whole series. I think that's a great way to reach out. But obviously we've got to do more, and not just going through the usual things like the TV and the newspaper. I think we've got to go through, you know, churches and the promotoras and the community health workers, just other ways, you know, people talking to people in the laundromats.
One thing I really like is, and they do it really well, I know we work with La Clinica de Familia, and I feel like they do it really well, is the community educators and promotores who are really part of their community and can speak to people and who in a way they'll understand and respect, and they have those relationships. And I think that's a great way to educate people about mental health.
As you deal with patients that might be coming in for the first time, how do you work to get them to commit to long-term care?
A lot of it's about the relationship. You really have to have a relationship between the therapist or the counselor and the patient. And again, we work very hard with our students in training on how to do that, how to establish rapport, how to be genuine, show that you really care, and create a feeling of we're in this together and we're alike, and I'm not judging you or looking down on you, and that you can trust me.
And one of the things about counseling that I think people often don't expect when they come in is it's really a collaborative relationship. So it's different from a traditional medical model, for the most part, where someone comes in, you diagnose them and tell them this is what you need to get better. It really is working hand in hand with the person you're working with. So you're not taking away their control, you're informing them of information about whatever they're struggling with and helping deal with it together.
You help them figure out what will help make their life better, and you support them while they try to make those changes.
What is the name of the clinic here at NMSU? That's kind of something that I just started thinking about. What's the name of the clinic?
It's a long one, NMSU Community Mental Health and Wellness Clinic.
Okay.
But the email is just theclinic@nmsu.
Oh, okay. Well, that makes it easier for people that may have questions. theclinic@nmsu.org. As we wrap this up, what's the takeaway that you want people to understand from what it is that these two departments are working together, that you want people to understand as to what you're doing?
I think it's a unique collaboration between sort of two different disciplines who've approached counseling and therapy, maybe using some different theories and models, but it's a chance for our programs to work together, our students to experience the different kinds of training methods and theories, and just sort of the synergy you get from having a collaboration.
Yeah, I think because we can collaborate and because we're training students in this integrative model, we hope they go out and think about integration as they go out and work in the field. And we want people to understand too that there's a lot of problems that come with stigma around mental health issues. And you can name those forever. I mean, there's abuse of prescription drugs, there's issues with how the police deal with people with mental illness, there's issues in the community. And so destigmatizing mental illness and treating it appropriately helps the whole community.
How
And we
have
want
the-
to be, oh, go ahead.
I'm sorry, how have the students reacted to this project?
It's been a great experience for them. They've really liked the opportunity to work with different kinds of clients, and I think it's really increased their skills and their confidence level before we send them out as full-fledged professionals.
Yeah, I would agree with that. I think it's been a very valuable experience, and we really hope the training we can provide is going to help communities beyond our community.
And what about the patients? What's been their reaction to this clinic?
I think they appreciate having the service, and while initially they might be a little concerned about having a student therapist, our therapists are really, and counselors are highly trained, and they're very well supervised by professionals. So we're not going to let anything happen that's not going to be a positive outcome. We have really, it's a really great treatment for the community.
And I think the evidence of that is we've really grown by word of mouth. So we haven't really done a lot of advertising. And it's really been, people have had good experiences in our clinic. They've received the services they need, and they've told other people. And that's how we keep having a steady stream of community clients coming in.
Well, my guests today have been Esther Duvall, PhD. She's the department head at NMSU Family and Consumer Sciences. And John Schwartz, PhD, Associate Dean of Research at the NMSU College of Education. Thank you very much for tuning in to Fronteras, A Changing America, on today's special Fronteras, as we have From Stigma to Treatment, Latinos and Mental Health. Thank you.